all strata of societies, all aspects of life. India and other countries embarked on a lockdown to delay or reduce the spread of infection. Perhaps it did succeed to some extent in delaying the spread, but had very serious adverse impact on economy, employment, and emoluments. There had been a steep decline in the purchasing power, especially among poorer segments of population, raising the specter of rising food insecurity and undernutrition. Steps to ensure agricultural production and, more important, improve access to subsidized or free food have become critical to prevent. Would all participants kindly mute, because otherwise we hear other noises coming in and that distracts all of us. There has been an attempt to provide subsidized food or free food in order to prevent steep fall in dietary intake and potential rise in undernutrition, especially among the vulnerable segments of population. All countries and all UN organizations have reviewed the situation regarding food security in COVID pandemic and helped in formulation of appropriate interventions. Health system in all countries had to take on the additional workload to provide health care for persons with COVID-19. India has been successful in screening persons, providing the needed care to those who tested positive, and keeping case fatality rates relatively low. These activities, however, to some extent resulted in decline of access to health care for communicable diseases, non-communicable diseases, elective medical and surgical interventions, immunization, antenatal, and delivery care. Healthcare seekers also to some extent were hesitant to come to hospitals for fear of contracting SARS-CoV-2 infection. Efforts are currently under to improve access and utilization of services under disease control programs, maternal child health, and elective intervention. A review of global and Indian scenario pertaining to food security and Indian scenario pertaining to health care in the first year of COVID pandemic is indeed timely. Experience gained in the last 12 months may provide useful lessons on how to learn to live with COVID-19 in 2021. To update the nutrition and health professionals on these aspects, NFI is organizing a webinar today. The theme of the webinar is Food Security and Health During COVID Pandemic 2020. We have three major presentations. Dr. Daniel Gustafsson, formerly FAO representative to India and currently the special representative of Director General of FAO, will be talking to us on global food security during COVID pandemic in 2020. I will follow him with food security situation in India. The final presentation will be made by Dr. C.S. Reddy, former head of the Department of Preventive and Social Medicine, Banaras Hindu University, and retired NPO, WHO India. He is currently the chairperson of ICMR Task Force on COVID and Public Health. I would like to welcome all the participants, and I would take the liberty of telling you a few housekeeping announcements so that the participation in the seminar is pleasant, clear, and orderly. I would first request all of you to please mute your systems, because otherwise inadvertent noises, talk, and even traffic noise outside your house window can really be serious interruptions to other participants. If you have problems with bandwidth, as many of us do have, cut off your video. You will see the presentation better and hear better. Following each presentation, there is a 10-minute slot for discussion. Please keep typing your queries in the chat box as and when they come to your mind. Mr. Brijesh, our web service provider, will project these queries to the speaker at the end of his presentation, and the speaker will answer the questions. It's possible that due to time constraints, it may not be possible for the speaker to answer all the questions. Mr. Brijesh will then mail all unanswered questions to the speakers, and they will send you their replies. After the webinar is over, we will mail all participants an evaluation form. Please complete this form and absolutely give your very honest opinion. We want to improve, and we keep having webinar after webinar on various topics. If there are things that we are doing right, we want to know about it and strengthen it. If there are things that we are not doing right, we want to know about it and correct. So please help us by this simple mechanism to improve our performance. There will be those students and postgraduates who would require certificates. Please fill the post-webinar questionnaire form and mail it to us. We will mail you the webinar. As soon as the webinar is over, we will mail you the form. And within a week after we receive your completed questionnaire, we will try to send you your certificates. Thank you very much. May I now request Dr. Daniel Gustafsson to start his presentation.
Very good. Thank you very much, Dr. Prema. It is just a real honor and a privilege for me to participate today. You know, I've been an admirer of NFI for so many years, and I've learned so much from you and the other old friends and colleagues on that I see today. So it just is a real pleasure for me to do this. Let me just start my screen.
Okay.
And
it has come.
Okay, let's see. I want to. There we go. Okay, now, very good. So this, as requested, is the global overview, particularly on, let's say, kind of the indicators and where we are, what we know and kind of what we don't know. And I think some of this will be, I think, quite basic for many of you, but I think it may be helpful to kind of go over some of the basics on how we measure globally food security and malnutrition, and think about how that then relates to the actions and the impacts of COVID. It's also, I think, for all of us, a particularly interesting and important crisis in that it affects all of us. I think like nothing else that we have had before. I mean, of all the colleagues in FAO, every country, end of the year, you're sending greetings and so on. We are all affected by this. And we know the background. We know it's the largest economic contraction since the Great Depression, the number of individuals who have been infected, those who have died, unemployment, as Dr. Prema mentioned, and the impact on the economy. And the economy I'm going to get back to in a couple of the slides, because it is so critical in particular in how we measure this. And India, of course, is not alone in the downturn. These are from the latest information from IMF,
ਉਹਨੇ soil ਲੈ
Um,
ਲਈ ਸੀਗੀ ਤੁਹਾਡੇ
and
ਕੋਲੋਂ
Spain,
ਚੀਨੀ
I think,
ਸਾਰੀ
was
ਆਪਾਂ ਨੂੰ
about the
ਮਿਲ ਗਈ
highest at about 11%.
ਤੇ ਅਸੀਂ
And it affected, of course, the more advanced economies much more so than the least developed countries. The least developed countries were, let's say, later to be affected and had the smaller level of infection and smaller impact on the economy, and we'll get back to that in a second. So what I would like to talk about then is how to make sense of what we know and what we expect to see once we actually have more complete data on 2020. There's no question that the impact has just been dramatic. And in addition to being dramatic in 2020, the food security and nutrition indicators globally in 2019 were already bad, and they had been in fact getting worse from about 2014 onward. So I think if we look at what's behind this increasing food insecurity and malnutrition, it helps us think through then globally how it has impacted households and overall populations. As I mentioned, most of the numbers so far are in fact estimates of what we think happened last year and what we think is happening this year. And finally, as you will see, and I hope to emphasize throughout, I'm just delighted that I can start out with this, but really we always have to look at national indicators. And in a country as data rich as India, it's interesting to look at the global numbers. There's a role for them. It helps a lot in a number of ways, but really we need to look at the national indicators and understand what's happening in the countries. So in putting the pieces together of what I would like to explain, I'm going to start out real quickly on what the measures of food security and nutrition are globally that we're talking about. Look at the numbers of pre-COVID 2019, what happened, what were the underlying causes of that, quickly look at what we think happened with COVID-19 and the restrictions, how that has played through, and then look finally at the estimates of what we think the numbers are now. So as most of you will know, there are really these big divides in what we look at global indicators along two dimensions, each with sort of two parts. The first one is the difference between food security and malnutrition, which we report on globally and at the country level. Also looking at food security, which is defined as really reliable, consistent, healthy, safe food access throughout the year and kind of a longer term access to food and healthy food, and versus malnutrition indicators, which are really anthropometric, stunting and wasting and so on, and that are actual measures of the impact of food insecurity or other problems on actual measures of what's happening with individuals. And then we also look, the other big divide between chronic malnutrition and chronic food security, that would be long-term vulnerabilities. We think for example, in terms of child stunting, you know, the small stature for age, versus acute food insecurity and acute malnutrition, where we think of really the outcomes of crises and emergency situations, and we think in that case more of child wasting, for example, among others. So there are two main global reports that come out from FAO and the UN, looking at, on the one hand, the chronic side, and on the other hand, looking at the acute side. As you'll see on the screen on the left is the state of food insecurity, actually the state of food security and nutrition, still known as SOFI when it was when we were talking about food insecurity, that has both now a global report and then regional reports. The regional report just came out. In particular, I think the 2020 report is really excellent and is just loaded with information, much more than I think we used to do in the past. Historically, of course, it's been around food insecurity. Now it also contains a lot of information on nutrition because it's now done jointly with UNICEF, WFP, WHO, and in the case of the global report, also with IFAD. And then on the acute side, a report that has been coming out since 2016, of which FAO, WFP, WHO and others are participants, is the Global Report on Food Crises that is done by a consortium of 15 agencies. So when we look at what SOFI has, it has basically two now SDG food security indicators. The SDG 2 is on food security and nutrition. SDG 2.1 is about measuring that. And historically, what SOFI has produced is the prevalence of undernutrition, often referred to as POU, both as a number globally and as a percentage globally and by country. And it looks really only at calories. And this is, on the one hand, of course, a major limitation in how we think of food insecurity, how we think of nutrition. But in fact, it is, I think, a remarkable number in many ways, in that it can be calculated more or less every year for every country. And consequently then has to be based on parameters that are relatively easy to obtain in every country more or less every year. And that is basically about cereal production and its production, consumption, trade, carryover stocks, and so on, size of the population, and where the statistics get to be the analysis quite complicated is on the distribution, the inequality of access to that dietary energy consumption. Consequently, over time, as better information comes in that allow the statistics part of FAO to make that calculation, the series has been then often revised going backwards. So we had a very big revision this last year in the 2020 report looking at 2019 numbers because of much better estimates on the inequality of dietary energy consumption in China. And we'll see that in a graph in a couple of slides hence. And then the new indicator, very interesting for those of you, some of you have probably followed this, is called the Food Insecurity Experience Scale. That also called FIES, at least among the people who work on it. And it's based on sampling at the national level and interviews regarding people's direct experience in their lives. Within the global Gallup questionnaire, we've added 8 questions to that larger survey sampling, and that leads to 2 numbers: the percentage of people and the number of who suffer severe food insecurity, and also moderate. But in line with what the SDG indicators are, there are 2 numbers reported, one on those suffering from severe insecurity, and then the other, the combined moderate and severe categories. And that's what is reported. And this is the definition of what those are within that food insecurity experience scale, between the moderate food insecurity where people are facing uncertainties, they've been forced to compromise on the quality of food they consume, and then the questions that get at severe food insecurity of people really experiencing very severe problems. They've typically run out of food and have gone for a day or days without eating. So those are what comes out of those 8 questions on a scientific sample. And then what is given is the number and the percentage of the population that are in those 2 categories. Then turning to the other report, the Global Food Crises report, that is relatively new and is not so well known, I think. It looks at acute food insecurity and malnutrition, really the countries that are in crisis. It doesn't cover every country. It covers those that are in that situation and where we can get data. And it has increased steadily since 2016, but of course it may go down if there are fewer countries in crisis. And particularly important, it, across these 15 agencies, comes up with a consensus view on both the numbers of people who are in different types of crises and how severe it is between one country and another, and also within a country. So how do you compare, for example, South Sudan and, let's say, Yemen at the moment, with both countries with a lot of problems, but which one is worse? How do you know? And this was really what driven originally by the donor countries and WFP and other UNICEF and so on, in looking at how to compare those. And then within that methodology called the integrated phase classification method, it determines the levels of stress within the country, or within that part of the country, or within families, and ranges between minimal, which is sort of the normal, to crisis, emergency, and phase 5 is famine. In addition, the annual report has a lot of information on acute malnutrition, the percentage of children suffering different various degrees of wasting, and other data, and then those anthropometric data and others are combined to then determine which classification it is. And it is a very comprehensive report, not only for the global number, but really looking in depth at each of the countries that are included. There were 55 included in 2019 for the 2020 report. So these are, if you can read this, this is the brief description of the 5 levels. Famine, we know, I mean, is really a catastrophic situation. In the emergency classification, you have a very large number of people then with high acute malnutrition and who have begun now to sell off their assets and do other things that really are in a very dire emergency situation. And below that, you have phase 3, in which they either have very high, above usual acute malnutrition, or they are just barely on the edge of being able to meet their food needs, but only by depleting other assets that they have in order to cope, selling off their livestock or whatever that might be. And below that, you have stressed, which is not good. They have minimally adequate consumption, and they are able to get by, but just barely, and then minimal. So when we report the numbers on this, generally we are looking at the numbers that are in phases 3, 4, and 5, either in crisis, where they're already really in crisis, or an emergency, or they're beyond the crisis, or catastrophic, where really it is famine. These are the 15 agencies that work together and coming up with, as you can imagine, with consensus on the numbers, and the methodology is a very interesting, I think, exercise, and I really salute the team that works on that. Okay, so if we look at the numbers pre-COVID, and we see how things were not good. Pre-COVID, 690 million people, around 9% of the global population, undernourished in terms of calories, and that was up 10 million from the year before, and it's up by 60 million over the last 5 years. In terms of the questionnaire, the FIAS indicator, 750 million affected by severe food insecurity, which I think is in some ways sort of, let's say, I'm happy to see it as relatively in the same ballpark as the SOFI number of 690, because the SOFI number, of course, is such a crude estimate. Wonderful that it can be done every year and for almost every country, but the FIAS indicator is really, I think, a very interesting complement, and 2,000 million suffering from severe or moderate food insecurity. Then when we look at the SOFI numbers, 21% children stunted, 7% wasted, and about 5.6% overweight. So that, I think you could all see. This is the interesting graphic of what happened from 2005 onwards. With the, you'll see from 2014, it was decreasing both in terms of number and percentage, not on track to get to 0 by 2030, but nevertheless sloping downward, and then starting in 2014 starts to then go up. And since the objective is to go to 0 by 2030. It gives an understanding of how off track we are. So you see then in terms of numbers, this is the 2019 number of 688. And I'm sure for some of you, and even for me, you wonder why 688. I mean, weren't we just talking about 800 not so long ago? But in fact, this is then where we get the impact of this better estimate from China. And the estimate, this was the old estimate without, well, let's say with the old data on distribution of the inequality of food consumption in China. Now, with the new data, you can see it's much more accurate and has dropped down significantly to this 680 number. And this would be the green line is the rest of the world without China. And you can see what happened. And it's kind of the same story going down to 2014 and then starting to rise again. So these are the numbers for those of you probably, I'm sure some of you have looked at them for India for this year's report for 2019. And, I would stress again, it can't really compete in any way with the much richer NSSO data and household surveys, but it is interesting, I think, to see also to gauge if we are sort of on track or not. In looking at that, so it is generally reported each year as the average of three years, and it's a moving average every 3 years. So for India, what was reported as a percentage of undernourished dropped from the 2004-2006 from 21.7, now dropped in the average of the last 3 years, 14%. Down to from 250 million to about 190 million. FIAS, interestingly, is collected in India with a sample size of that's I think about 3,000, but it's not reported yet because the governments have to agree if they want FIAS numbers reported, and government of India has so far not agreed to that. I don't think there's any particular objection, but it is a new indicator, and I think we'll see what happens. But so far, not reported, which is fine. I mean, in the case of the POU, we report for everyone. For FIAS, we only report for those countries where the government agrees to do that. And then the wasting number 17.3, the stunting. Went down from 37.4% in the let's say in the SOFI estimate that this is done, I think, mainly by UNICEF and WHO combined rather than the FAO portion, and came down from 47.8 to 37.4, at least in what's reported in the SOFI, and then the overweight number again declining from 2012 to 2019. So what happened? Why is this? Why did the numbers go up? And the basic rationale for that is this weak and deteriorating economic conditions since about 2014. Lower income, fewer remittances, always hugely important, and increasing poverty and undernourishment. Still, we know about 10% of the global population below the absolute poverty line that the World Bank uses of $1.90 per day, increasing debt burden, extreme weather events, spread of pests and diseases, desert locust in particular for East Africa and elsewhere, growing inequality, the uneven benefits, and lastly, among other things, an increase in conflict and violence with displacement of population that is now 70% higher in 2018, the last year that we have numbers for that, than it was in 2010. It's just, there are a lot of countries in crisis. And you can see that this, I'm sorry you can't read the countries very well, but it is true that since 2014, where the hunger increased, all of those countries are mainly middle income countries, of which most of FAO's members, of course, now are middle income, all suffered economic slowdown or downturns. And that, of course, we see then when we get to COVID, what happened. Okay, then if we turn to the Global Food Crisis Report, 135 million people in those 55 countries that were either in the crisis, emergency, or famine situation. It had gone up from 2016, as you see, but of course, they're not directly comparable because of the number of countries involved for which we have, but clearly 135 million people in phase 3 or above is really a tragedy. In addition to which, on this stressed category, those that are just sort of at the edge of getting by, is another 183 million in an additional 47 countries. So there are a lot of people in let's say who are not in the crisis situation, but are not in the minimal situation either. As you could imagine, the conflict and insecurity was the biggest factor of that. Along with economic shocks and weather extremes, drought mainly. And you can see, again, jumping ahead and thinking of COVID, somewhat related to conflict, somewhat related to weather, somewhat related to economic shocks, but really largely the big drivers of what happens to those people in phase 3, 4, or 5 in crisis, famine, and so on, goes beyond the impact of COVID. You see here of the 10 worst ones, their countries really in crisis: Yemen, Democratic Republic of Congo, and so on. And if you look at those, most of those, of course, are in conflict. Northern Nigeria, South Sudan, Afghanistan, Yemen, and so on. Not all of them. Venezuela is one for economic crisis, Haiti another one for economic crisis, Sudan. And that is of this total of 135 million. That was about 2/3, in fact, of the total. Okay, so now we look, that's 2019. Now we look and see what happened in 2020. And this, again, is something that we all have witnessed personally. Disruption in food supply chain. Every country in the United States, very clear how it affected at all income levels. Reduced employment and income, as Dr. Prema was mentioning. Reduced remittances, a major factor on poverty and food security. Market closure, instability, cost of healthy food in particular going up. Internal migration leading to more disease, further impacts, and of course, again, as Dr. Prema mentioned, much diminished social services, healthcare, school feeding, community-led services, all disrupted. Even in the home, disruption of childcare practices due to the quarantine, illness, death, and so on. In any case, in all of these areas, increasing the vulnerabilities of the most vulnerable, leading, as we would all expect, to much worse indicators. Among the interesting new data that has come out of actual, let's say, in a quantitative sense, is an interesting study I thought I would include real quickly on how the lockdowns have halted the movement of women much more than men. We know that women, let's say, have an unequal burden in this regard, and it's very interesting in data from Vodafone that was collected by the IMF together with Vodafone in Italy, Portugal, and Spain, and Southern Europe. And this is on what happened to people moving around that you could gauge from their mobile phones. And you can see how the increase disparity has affected women much more. And this, of course, is what we would see in a lot of different areas, but it's an interesting one with that kind of unique data set. So just in summary, this is the kind of graphic that we've been using to look at what how the impacts, the dynamics of COVID that then lead to worse food insecurity and nutrition. COVID-19 itself directly affecting supply chains, directly affecting deepening inequalities, and then because of the lockdown policies affecting all of those as well that you see there, and all of that leading to increased poverty and food security. Okay, so where are we with the numbers? What are we thinking? What do we have so far? And as we saw in looking, for example, at 2014 onward, a lot of the numbers particularly on food insecurity coming out of the SOFI and the prevalence of undernutrition will depend on economic growth and the consequent increase in poverty. And historically, anytime that the rate of growth slows down, even if it's positive, it's been bad, and that's the case from 2014 onward. But a negative number, where the economy is actually going backwards and getting smaller, not just increasing at a smaller rate, but actually getting smaller, is just a huge and dramatic impact. That, of course, continues into 2021. We are uncertain what will happen, particularly in areas where we have the least amount of data, and Africa, for example. What will happen there as the coronavirus spreads and so on. And I should say too that the estimates of economic growth, since that is such an important variable, are constantly being refined. So the most recent ones that I'll show in the next slide just came out last week from the IMF, and they look better than they looked in the October report, and those look better than in the April report. So partly it's because things are improving, and partly it's because we just have better information. There was a report, an analysis that came out on World Food Day in October last year by FAO on what the expected outcome might be of the impact of the pandemic under 3 different scenarios. And this is, I think it makes it look like a simpler calculation than it really was. But because we do put in the analysis the individual data for all the countries in terms of their growth rate and so on, it isn't like just a simple, let's say, entering one estimate of global growth, but how that is affected across countries, but with 3 different scenarios. And those would be an aggregate where there would be a reduction in global GDP of 4.9%, which is what the estimate was at the time, or somewhat worse at 7%, or really a very drastic reduce of 10%. And that would be an additional 83 to 132 million people who would, because of COVID, would fall then into the number of food insecure. So somewhere between then what we would expect at the current, without any change, 695 million may go up as high as 827. So then we look at the last week's update from the World Economic Outlook by the IMF, and their most recent projection shows, or the recent analysis, most recent, that the global economy, in fact, did not go down as much as even we were thinking of 4.9, but their current estimate is 3.5%. They expect it to go up 5.5% globally next year, and then back to down. You see how much more severe the impact was in the advanced economies, and in the emerging markets and developing economies less. So this 3.5% is the best estimate I think we have of what happened to the economy in 2020. So this is now then a very rough estimate. If it was in fact 3.5%, that would lead to somewhere around an additional 75 million people, or 11% more, attributable solely to the pandemic, in addition to the increase that we would have expected anyway. And that, I think, is an important number, but of course it's far from the complete picture of all of the impacts. And for that, we need anthropometric data, we need new household surveys, and eventually we will need the FIAS results that people will tell us how that affected them. And I think those are really going to be probably much worse than what we are seeing, but that's where we are at the moment. Then if you look at sort of the second part on the acute food insecurity, what do we have? And here we do actually have 39 countries of the around 55 that we will be looking at. And you can see, probably can't see very well, but you could see how that varies country to country. But overall, within those 39 countries where we have both data for 2020 and data for 2019, we see that it went up a lot. It went up by 22.4 million, a 21% increase of those that are in phase 3 or above. Now, in a number of those countries, the number of that are in those 3 categories may have even gone down, but it could be that the crisis is a lot more severe. So you could have a lot of people going into now in between, possibly even into phase 5 in Yemen, for example, even though the number looks to be somewhat smaller. But in any case, if that of these 39 countries, if we would just extrapolate that to the 55, these data will be out, will be published in April. But if it applied to all 55 with the same 21%, it would be around 163 million that would be in this crisis, emergency, or famine situation. And that is really a drastic number and higher than anything we have seen before. So just to conclude, I would say that certainly, let's say in addition to the numbers, it certainly has made all of us, I think, much more aware of the complexity of food systems. Here in the United States, for example, you couldn't buy flour in, let's say, a 2-kilo bag because so much of the flour had gone into the institutional segment of the market. No one was eating in the workplace. Schools were closed. Restaurants weren't serving food. It just disrupted the whole thing, even among the people who, let's say, have no difficulty in accessing food. And that is just multiplied in its impact wherever we go. What happened to employment because of the food system? What happened to internal migration because of farm laborers? All of that was just dramatically evident in every country in the world. It also, I think, reinforced the importance of looking at healthy diets and the affordability of healthy diets and what happens. We can't just look at calories. We've always known that. Much more emphasis on healthy diets and their affordability, and they are not at all affordable, even under the best of times, and that really has been exacerbated now with the crisis. As you see, and all of you know, vivid examples of these vulnerabilities that are just exploding because of the coronavirus impact and the lockdown, and the importance of social safety nets and the difficulty of making those social safety nets continue to work. And hopefully in this, as we recover, I mean, we are, looking forward to eventually vaccines and recovery, and the IMF, we're looking at back to economic growth this year. Let's see how we would put those lessons into practice. And I think India will be a leader in this. I don't have any doubt. And then again, just to conclude, I think, it's a useful element to have the UN and the others look at these broad sweep of the global numbers and to be able to do it essentially every year and to show where we are, if we are making progress on the sustainable development goals and so on. But really it is the national indicators, the national household surveys that really are the things to pay attention to within the country. And even, of course, as I mentioned, India, of course, very data-rich, excellent statistics and importance and analysis in that. But even in countries without that wealth of data, still looking at what's going on locally is a huge complement and a let's say, absolutely vital complement to looking at the sweep of these big global numbers that FAO and the colleagues in the UN are putting out. So I'll stop there and thank you all and look forward to your questions.
Thank you, Dr. Gustafson. That was a really excellent presentation. Clear, concise, telling you what is happening, where the data lacunae exist, and where we should concentrate in the coming year, or this year I should say, not coming year, in this year, so that we are better informed about the first year's impact on critical indicators on food security, health, and nutrition. The session is now open to question. May I request Brijesh to start sharing the chat box questions. Brijesh?
Yeah, sure, ma'am.
Okay, as of now, we have not received any questions, says Brijesh. Dr. Gustafson, I know it is 9 o'clock in the night in your place, but can you sort of keep awake for us for another hour so that
Oh my
perhaps
goodness.
questions will come?
Oh yeah, no. I'm happy to go as long as you want.
Okay, because maybe they will start asking you the questions after they hear the national presentation. Would you
Right.
mind staying on with us?
No. I mean, I need to continue learning, but yeah, no, absolutely. And I think, as I say, it's the combination really of the two that is always interesting. But by all means, it would be the pleasure is all mine to continue.
Thank you. Dr. Bamji, any questions? Malini?
No, I was just enjoying it. I don't have a specific question at this time, Prema. I have learned a lot though. Thank you.
Okay, there you are. We are still in the process of digesting what you had said, because the canvas that you covered was very, very wide. And, while broadly we are aware of what is happening, the rich details that you provided are really still in the process of assimilation. And that is why I think none of us are ready at the moment to ask you questions. And that includes me, who had a chance of looking at it earlier. But I enjoyed it immensely, Dr. Gustafson.
Okay, thanks very much. I would just add one additional plug, I think. I mean, I had to go back and read the SOFI report and the Global Food Crisis report again in preparation. And especially the SOFI report from 2020, I think is just a wealth of information that I think could be a textbook, in fact, for some people on how this is calculated and the background and the impacts and so on. I just found it to be an excellent study and a lot richer in detail than it had been in earlier times.
Thank you very much, Dr. Gustafson. I see that there are 4 questions there, Dr. Gustafson. Would you mind answering them?
Yes. Okay. So, yes. In fact, in the question on the efforts to influence economic stimulus packages, by all means, were designed to look at food insecurity, and I think in some cases successfully, in other cases not so successfully, because of the additional burden of making the social services work. The Europe and the U.S. and other countries as well put most of that impact, I think, into distribution of cash, whereas local governments and civil society, NGOs, and so on, put most of the emphasis into distribution and making sure that people were able to continue to have access to food. But it's been a major, in every country, just a major really major hurdles to doing that, especially with schools closed. And school closings have had just a tremendous impact on not only on education, but on school nutrition, on feeding programs, and so on. But where I think the policy aspect that I think where there was most success was in not having countries shut down their imports and exports, as happened during the food price crisis back in 2008 and so on. So to keep global trade going, and global trade is way down this year, but we did not have the disruption in global trade, especially around cereals, that I think had been feared that we would that might happen. And that, I think, the coordinated policy response, including through the UN and others, I think that was actually a successful policy response. And I think the other ones are more comments rather than questions, but I appreciate them.
Thank you. If there are no more questions, we will close the session now. But as you know, the option of sending questions continues to exist. And therefore, as and when you send the questions, if there are many more, we will send it to Dr. Gustafsson, and I'm sure he will be answering them. Aramarthi Bhuvaneshwar, will you mute yourself? Done. Anju Sinha also. Okay. I will now then start sharing my presentation. Has it happened?
Yes, ma'am.
Not really. No, you are doing or I'm doing.
Yes, you are doing.
But for no, it's not on my Zoom. Get onto the Zoom. Get onto the Zoom. That's what I'm doing here. Get that. View. Yeah, but where is your presentation? It's not open. No? It is open. Okay, get open that. New share. Okay. Do not see it.
Yeah.
It's shared. Okay, but why is it that I'm not seeing it?
But you put it on PowerPoint.
You will be only giving this screen.
चलो आ जाओ 1 मिनट करेक्ट कर दो.
You will be able to view only this screen. Just start. Yeah, go ahead.
Okay. Today I will be talking about food security in India during COVID-19 epidemic. First, of course, lockdown and its impact. As health professionals, we always believe saving lives is of highest priority, and this is what happened. In January 2020, China reported that what began as a respiratory illness in Wuhan city within 3 months spread to entire Hubei province, across China and across continents. China, Italy, and Spain reported that their hospitals are overflowing with persons requiring admissions for severe respiratory illness, and that case fatality rates in admitted cases ranged between 16 and 20%. Alarming situation to a country with 1.3 billion population and severe overcrowding across the country. It was hardly surprising, therefore, that India imposed a strict lockdown to delay the spread of SARS-CoV-2 infection in the country on 25th March 2020. At that time, the daily new cases were 56 for this entire country of 1.3 billion. Total reported cases were less than 600. The lockdown did give time for the health services to reorganize so that they could take up the job of screening, admitting and treating cases, and also adapt appropriate quarantine contact tracing measures. These did result both in reduction in number of cases and in minimizing the number of deaths. But as has been stated already, lockdown brought economic activities to a standstill and endangered food security for millions. So we did not have any option but to begin a phased unlocking with precautions to prevent the spread of SARS-CoV-2 infection. These initiatives were taken up in June 2020. Cardinal principles during unlocking were prevent further job loss in urban areas, increase support to rural employment through NREGA, try to enable children to learn congregations, use masks, ensure physical distancing and hand washing to prevent spread of infection. There was a fair amount of adherence to these precautions. It is never possible to have 100% compliance, but by and large, urban overcrowded areas did follow many of these practices. Despite these precautions, there was a steady rise in the cases. But here again, life is relative. If you look at cases per million or deaths per million, India had a relatively low caseload and deaths per million. In addition, we are rather proud of the fact that case fatality rates in India always was around 1.5 in spite of ups and downs in the number of cases that health service has to cope with. We really started unlocking in a more vigorous fashion and started doing economic activity resurgence by October 1st. And strangely, there has been a progressive fall in the relative new cases since this time. This is despite the fact that October, November are festival seasons in India. There is overcrowding and relative non-compliance with precautions across the country. Contrary to the trend in USA and Europe, fall in number of new cases continued even after the onset of winter. And this winter has been pretty severe in northern parts of the country. Currently, the reported number of cases, new cases, are similar to those reported in June 2020. But some data from zero surveillance suggest, mind you, this is not yet the nationwide zero surveillance data. We have bits and pieces of zero surveillance in several urban areas. But the suggestion is that proportion of people with antibodies due to prior infection may be as high as 60% in Indian population. We do not know clearly which of this is responsible for the well-defined fall and sustained fall in new cases over the last 3 months. But we know one thing, higher mobility after unlocking resulted in relatively higher number of cases in most countries. But in India, unlocking was not followed by this rise in number of new cases. This might be partly because lockdown continues even today for education, entertainment, and activities related to meeting. It is ages since I attended any scientific meeting physically. Compliance with mask wearing and physical distancing is high, especially in congested urban localities. So, what is the take-home message? So far, so good. We don't understand why, but we seem to be having a respite. But This respite should only give us the stimulus to get the health system back to providing care both for COVID and for non-COVID related health problems. And this respite should be used for accelerating the employment and economic recovery. We'll now move on to see the lockdown and its impact on food security. For obvious reasons, most of the data are process indicators. It is too early to assess impact. Too few surveys have been conducted, and therefore all data is essentially on processes that have happened during the year 2020. India had imposed one of the most stringent lockdowns between March and May 2020. It was 100%. Literally every single nook and cranny, main streets and highways were locked down. USA imposed a lockdown which was 70% when they had more than 1 lakh cases. More important than that is the fact that even after unlock began, the conditions of lockdown has been sustained at 75% till October, and thereafter over 70% till December. That is, still education, entertainment, restaurants, congregations, meetings are all not happening. Whether this is a major reason why relatively few cases are there today is something that we need to ponder about. I thought pictures tell you stories much better than 1,000 words. And here you can see the bustling construction activity laden 4-lane traffic are all empty. Empty as if it's somewhere in Mars. In India, we know internal migration for economic reasons is very, very common. There are clear-cut areas from which outward migration occurs. Uttar Pradesh, Bihar, Orissa are some of the major places from which outward migration occurs. Maharashtra, Delhi, Haryana, Uttar Pradesh, and Gujarat are places to which migrants go. In one fell stroke, when lockdown was imposed, 1/4 of the workforce in informal sector in urban areas lost their jobs. The impact of lockdown on migrant population was really tremendous. 83% did not find work. 80% ran out of rations. Because of lockdown, they had no capacity to return back to their villages. So, what do? They tried by whatever means that were possible to get back home, because food was a problem, but shelter was another problem. Where will they stay when they didn't have money to pay the room rent for their small tenements? So they had no choice but to try to return to their villages. They found any and every mode of transport. Many walked with families and walked with children. This was widely reported in India and really brought a huge number of interventions, not only on the part of the government. And what was very touching was on the part of people. People anywhere, everywhere, across the roads, that these people, migrant laborers and their families, were tracked down relief measures. All countries responded to COVID pandemic by providing cash transfers and kind transfers. South Asia essentially responded with kind transfers. Over 3/4 in India received assistance mainly as food grains or cooked food to ward off food insecurity and hunger. But cash transfers and employment programs in a country like India was not at all insignificant. Direct cash transfers were effected for 420 million individuals, 42 crores, about a third of the population. More than 20 crores, 200 women got cash transferred to their bank accounts. Cash support was provided to building and construction workers, and additional working capital was provided to farmers through the cooperative agency NABARD. Because of widespread IT-enabled services, the pace of getting the transfer was swift. This does not mean that all people who needed the money got the money, that all cash transfers happened without a hitch, or that inevitable leakages were totally plugged. But they were kept within reasonable limits, which is all that can be expected when you deal with a country which is as vast and as varied as India is. In addition, additional allocations were made to employment programs to improve employment and earnings. The Mahatma Gandhi National Rural Employment Guarantee Program received additional funds. In addition, a special program called Garib Kalyan Rozgar Abhiyan was launched on 20th June to cover a period of 125 days in 116 districts in 6 states. This was aimed at providing employment and livelihood opportunities to migrant workers who returned to their villages in rural areas during COVID pandemic. A specific group was identified and efforts were made to provide work to them so that they can earn, and that will improve their purchasing power. Providing food during the lockdown was another major intervention that India did. In this, we were very fortunate that food production in India has been increasing as projected in the last 5 years. There were adequate stock of food grains. In 2013, India enacted the globe's first National Food Security Act. This legislation provided for highly subsidized food grains to 2/3 of India's population as a legal entitlement. Availability of adequate food grains and food security to the country's millions affected by COVID-related lockdown problems in the country. They were all provided with 35 kg of cereals, 5 kg of pulses, free of cost between 1st April and 31st November 2020. Some states are continuing to make provisions for free food grains even today. In addition to this, almost all cities and towns in the country organized the midday meal kitchens to cook and provide 2 hot-cooked meals to all those who came to food distribution centers. These measures ensured that despite massive unemployment and reduction in wages, the poorer segments of population were able to ward off hunger. You can clearly see the people who have come and collected their rations. As you can see, you see poorly dressed poor people, but they are not wasted, they are not famine stricken, and they are carrying adequate food grains for a fortnight for their family. Hot cooked meals were served. This is a school in which an NGO had supplied hot cooked meal to women and children. Similarly, NGOs and citizens group cooked and served meals twice a day in many cities and towns. I would again like to point out these are organized activities wherein there was considerable amount of organization, lack of chaos, and cleanliness. When the migrants reached their villages, they were initially kept in temporary shelters away from the village because the villagers feared that living in crowded localities in the city, they might have been infected in the city and they might bring infection into the villages. So they were quarantined, if you want to use the word. Some places where temporary shelters were provided for them outside the village limits. After 2 weeks, they were accepted into the village. But because they didn't have employment, they were food insecure. The community, the village community, provided them food, not only during quarantine, but also after they were taken into the families, because the families themselves did not have adequate food to feed the additional migrant members who have come back home. In villages, some got both cooked food and rations. It is estimated that all these measures prevented hunger both in urban and rural areas to an estimated 60 to 17 million migrant families. That is fine, they didn't starve. But how long can they continue there in the villages without remunerative employment? So, with the revival of urban employment starting from August, September, and October, many of the migrants started returning to the cities. Jobs there were not plentiful. Often they were temporary and at a lower wages. But provision of free food grains and free food till end of November 2020 helped even the returned migrant workers to urban areas to ward off hunger. When train services were resumed, many state and central government provided the migrants the money to buy train tickets to get back home. In addition, returning migrants were provided with food grains and cooked food for the journey. So the highest priority was provided to ensuring the food reaches the hungry all through the lockdown, the travails that happened thereafter, and also when we are trying to get back life towards normalcy. If this is the story of lockdown and phased unlocking, what do we have in future? How do we learn to live with SARS-CoV-2 infection? And what is the road to economic recovery? The Economic Survey of India was presented to the Parliament on 29th of January. And most of the data that I'm going to present on this road to recovery come from Economic Survey. The Economic Survey acknowledged that India faced a severe demand and supply side economic shock in the first and second quarter of the financial year 2021. There was demand shock because of reduced investment, reduced demand for non-essentials, and reduced consumption of essentials because of wage and income loss. So, this part to some extent, reduction in consumption due to wage and income loss, essentially food, was tackled by the measures taken by the center, state, and the people themselves. On the supply side, labor supply shock. Majority of laborers cannot work from home. There was disruption of supply chain. and both demand and supply shock aggravated each other. The stringency of lockdown was across the world related to GDP growth decline. India, which had the most stringent lockdown, also faced the most stringent economic loss. Unlocking in a phased manner to some extent has reduced unemployment, but as I said earlier, the wages are still very low. But economic survey, green in color, is optimistic. It assures us the worst period is behind us. There are green shoots in all sectors, in all economic activity, and the country will have a V-shaped economic recovery. Projected GDP growth for year 21-22 is 11.1%. Of course, if you look at the difference, starting with the base year 2021 as low as minus 7.7, this is not huge amount, but it is something. There are, however, another set of economists who worry, yes, there will be economic recovery, but will it be equitable and V-shaped, or will it be K-shaped and further widen inequalities? Time will only tell, and hopefully all of us who have been alerted by this possibility would strive to ensure that the recovery remains V-shaped and not K-shaped. The economic survey also makes one more statement. As compared to other regions in the world, India implemented the strictest lockdown and experienced the deepest dip in GDP. So, because of all this, currently India is witnessing a continuing decrease in cases. Vaccines are being made available. Economic activities in India will bounce back faster. And it's logical to explain that country may experience a steeper increase in GDP as compared to other regions of the world. Hope this does happen. Let's now look at economic access to food. Employment has always been the major worry for all of us. There was a steep reduction in employment in April 2020. But with unlocking, progressively there has been an improvement in employment. But even in December 2020, there is a 5% less employment as compared to pre-lockdown period. The gender disparity that Dr. Gustafsson pointed out is very stark in India. Post-lockdown recovery was sustained in about 70% of men.
To enable the textile industry to become globally competitive, attract large investments and boost employment generation, a scheme...
Will you please mute? Oh, sorry. 1/5 of the men, and the sustained recovery in women was only about 25%. 1/5 of men and over 1/2 of the women, there was no post-lockdown recovery. This gender inequality is something that we ought to really pay serious attention to. What happened to people who were salaried employment? These are small-scale surveys which need to be fleshed out in larger context, but it at least gives you some pointers. Among those who had salaried employment in December 2019, only about 40% continued in the same vein right through. Over 40% had to shift over to informal employment, and 1/6 of them were totally out of work. There was substantial reduction in monthly wages to all categories of worker. Permanent salaried employees, 13%. Temporary salaried employees faced 22.5% reduction in salaries. Casual employees, 1/4 reduction, and even self-employed persons suffered a drop in earnings. Over a third of rural and 1/10 of urban population, you can see rural employment was not that badly impacted. Urban employment really had huge impact. The recovery rate was higher in urban employment as compared to rural employment, but this is partly because the rural employment was unaltered as compared to pre-COVID time. The proportion who remained unemployed is common both in urban and in rural areas. Both in urban and in rural areas, there has been a decline in post-lockdown earning as compared to pre-lockdown area. The reduction, of course, was more marked in urban areas, but please remember, the rural areas provide us all the food that we need, and we all recognize it for survival. To see that that group had a major suffering is something that we actually have to take great note of. What is happening to the unemployment rate? The Center for Monitoring Indian Economy is the source from which I have taken this data. As has been stated clearly, 1/5 was the employment loss in the months of April and May. There has been a progressive recovery both in urban and rural areas. But however, please note that even in 2020 December, unemployment rates were higher as compared to January 2020, both in urban and rural areas. Yet another criteria, NREGA enrollment, even as of December 2020 and January 2021 is high. That means unemployment is a still major problem. Economic access to food is affected by one another economic factor, that is food inflation. Let's look at food inflation. Unfortunately, over the last 2 years, food inflation was always higher as compared to general inflation. This continued during the COVID pandemic too. Both wholesale and retail food inflation continued to be high, and when combined with unemployment and wages falling down, inflation rendered economic access to food far more difficult, especially for persons working in informal sector at low wages. If you look at the contribution of CPIC, inflation in food and beverages was the one that contributed maximum to this. It's not only that food inflation as a whole has been high throughout the year. Please note that cereal inflation has been relatively low, but pulses and pulse-related products and vegetables have huge inflation across the year. This also animal food. These have nutritional implications much beyond hunger satisfaction. Finally, one way to look at it is not through foodstuffs, but what has been the cost of a vegetarian thali. Both in urban and rural areas, there has been an upward trend in the cost of this, and therefore, this will have some impact on the type of food consumed by families, especially among the lower segments. This will affect adversely pulses, vegetables, which are very important from nutrition point of view. Let us look at one green shoot which keeps us all going. It is availability of food. The estimated fall in sectoral growth in the worst affected April to June quarter was the least in agricultural and allied areas. Adequate production and transport of foodstuffs was the major factor that enabled the government to initiate steps to prevent a steep increase in household food insecurity between April and December 2020. Trends in food production in rice and wheat crops over years and other food crops are shown in this picture. The source is Economic Survey of India. We are heading towards a very record high in terms of cereal production. Pulse production has been adequate. Procurement in rice and wheat and storage has been adequate right through the year 2020 and continued without any disruptions. Because of this, the country is enabled to export food grains to needy neighbors, and that includes Myanmar and China. Food grain production and procurement continue to grow, but please note, rural incomes have not shown a similar trend. It is imperative that agriculture and allied activities are made more remunerative so that the productivity continues to increase. This is a critical input needed to ensure food security at home. Export to neighboring countries needing food grains will help them to also provide food security to their citizens. It comes under the same heading: vaccines to ward off COVID, food grains to ward off hunger, and neighborhood comes first. What about vegetable and fruit production? We have been growing vegetables and fruits. Farmers have taken it to their heart that they should diversify production. And today India produces, it's number 1 or number 2 in all vegetable production. We are not talking about malls, but here are roadside vendors. And this is winter 2020 in Delhi. Fresh, nice vegetables are available. But farmers have faced huge problems in transporting and marketing vegetables. Wastage of vegetables was phenomenal during lockdown. Farmers were adversely affected because of wastage-related loss. Majority of consumers were unable to afford. The prices shot up because adequate vegetables were not reaching urban markets. So vegetable consumption suffered. How do we learn to live and cope with SARS-CoV-2 epidemic? India is opening up the lockdown in a phased manner. We must congratulate the health sector for having coped with providing care for persons with SARS-CoV-2 infection across the year. Cases and deaths have remained low. There had been a steady fall in confirmed cases and deaths, but vigilance is needed. We do not know whether the second wave will come. If so, when? What will be its magnitude? And will the second wave bring in its wake a higher spreading rate and a higher mortality rate? These are things that we do not know. But health services have to be prepared to meet these eventualities. In the coming month, health services will also have to gear up to halt and reverse the trend in reduction in access to preventive and promotive care in MCH, disease control programs, elective procedures, and restore them to the pre-COVID-19 era level. This is essential to prevent increase in morbidity due to, and certainly maybe even mortality due to illnesses other than COVID-19. There is an urgent need to reinforce health education messages that all these efforts of the health sector require close cooperation of all citizens in terms of universal adherence to physical distancing, wearing masks to reduce the risk of transmission of all respiratory infections, including COVID-19, in healthcare settings. With the resumption of economic activities, there has been some improvement in economic indices. Focus will have to be on economic growth linked to employment and wage growth. Agriculture has been the sheet anchor which enabled the country to provide food for all the needy for over several months. Remunerative prices for foodstuffs, increased storage capacity to prevent gluts and distress sale, technology for processing vegetables to prevent wastage, adequate marketing facilities will enable agriculture to continue to be productive. We need to ensure that people who toil to keep us food secure do get adequate economic returns for their hard work. There are fears that resumed economic growth may not be similar across sectors and may widen disparities. These fears should be allayed. I would end by a fervent personal plea. The COVID epidemic has shown us what is essential for life and what, at best, are icing on the cake, which are nice if they are there, but not essential. It should be our endeavor to protect the essential ones. And what are those essential ones? As I said, food is the fundamental basis of all living. We need to ensure that even though it today accounts for no more than 20% of GDP, Indian GDP, agriculture and allied sectors are given the respect that is due, need all attention that they need, and ensure that they do get all inputs that are necessary for them to continue being as productive as they are. The second is health. India's health services, despite their numerous inadequacies, disparities, and problems, have played a vital role in ensuring that essential health care needed in the COVID era is provided. Please consider the desperate need for ensuring health of all the citizens by enabling the country's citizens to access universal health care. This should be considered as yet another essential prerequisite for healthy living. And 5% GDP is not too much to spend on such an important endeavor. So, would efforts that are being made in 2021 onwards keep these important sectors also in focus, so that the lessons that we learned during COVID epidemic would in fact serve us much, much better in the coming decade. Thank you very much. Share chat. Okay. I would now try to answer some of the questions that have been posed. Were there any specific efforts to influence economic stimulus packages post-COVID, to influence food insecurity and programs? You know, economic stimulus packages were focused essentially on small and medium enterprises to increase economic activity in these sectors, which provide much greater employment potential than major enterprises. But, you know, any investment in them will take time for that to mature, that to become operational, and that in turn to become fruitful in terms of providing better food security to the families of people who are employed there. Immediate essential interventions to reduce food insecurity were provision of free food grains, provision of free cooked meals, increasing allocations for both NREGA and also for the Garib Kalyan Yojana. So that is where I think people benefited a lot in the immediate COVID period. That is, however, not what is going to help you in terms of improving economic activity, increasing GDP. So those aspects should now receive greater attention. The second question is excellent insight into impact of pandemic in Indian situation. Since feeding programs were disrupted during COVID, especially for children, midday meal and ICDS, what will be the impact on nutritional status of children? Excellent question. We do not know the answer. At the moment, I think what we know is ICDS tried providing some take-home rations. We do not know the reach. We need to get data on how many, what are the areas which had better coverage, etc. So process indicators from ICDS. Midday meal program, of course, was totally interrupted because schools are not open. We do not have any information at all on nutritional status, as I said. Our advantage is that we have 2019 National Family Health Survey 5. If we conduct a survey perhaps in 21-22 or perhaps 22-23, that will provide us nutritional impact on vulnerable groups, vulnerable age groups, mothers, children in a disaggregated fashion. Next question, Dr. Gustafsson. When migrants returned to rural areas, was there an increase in infection that was registered? We do not have an answer to this. We all feared it. We communicated it to the villagers, and that's why they quarantined them, and their quarantine efforts were damn good. Okay, I think we should learn from them. They kept them away from the village, but fed them, clothed them, gave them adequate warm clothes when winter came. So that was a very, very good demonstration what people can do to their own folks under all constraints. What happened to infection? We do not know really what is happening to infections in rural areas. The serosurveillance surveys is the method by which we may be able to disaggregate at a later date what could have been the infection rates pre-return, post-return. The second question is there a possible explanation now about why antibodies are as widespread as 60% in the population. Dr. Gustafson, this is nothing new. Bombay had taken up serosurveillance in limited urban population. Dharavi, which is the greatest slum in Asia, recorded a 60% positivity rate somewhere in their somewhere in October, November. So congested living and high level of city infections both contributed to this. In the same city, residential areas occupied by upper income group had a prevalence of about 20%. So those disparities exist. We are conducting more serosurveillance, but serial data would be required. There is also one question that you did not ask, but I would like to answer. There are many of us who have been collecting serum samples over time in smaller population groups. So you do have a longitudinal capacity to do longitudinal seroprevalence studies. Pre-COVID in 2019 December, pre-COVID March 2020, and COVID October, December, and 2021 January and more. We also have nutritional status data of smaller population groups. What has happened to them during lockdown? None of us have data, but post-lockdown from October onwards, nutrition data is available. Comparisons there would also enable us what is the magnitude of increase in severity and quantum of increase in terms of prevalence. So let us see what can be done over the next few months. We will keep coming back with all the knowledge that we are getting. Next question, Dr. Kurpal. We are all concerned that whatever GDP jumps up, social disparities will increase. Are there lessons from the past that we can use to mitigate this? I do not know. But my fervent plea with which I ended, that is, please support two vulnerable segments that I know. The rural agricultural residual population who produce food but are among the poorest in the land in the country. We should look after their requirements in a sustainable fashion. I'm not saying food doles at all, but enable them to be productive, enable them to get remunerative employment right through the year. The second is, all of us do know health, irrespective of GDP and irrespective of other things, does help in keeping you well nourished. So universal access to healthcare should also receive due attention. At least it will have impact on two important segments, and that is the hope with which I go. I don't think there are any more questions. Are there any other questions? Anybody would like to? Yes, Dr. Bamji. Okay. Yes, Dr. Bamji. We can't, please unmute. Unmute. She has unmuted. But why is it we are not hearing her? Huh?
Maybe she is not connected with the headphone. She's wearing a headphone.
Will you unmute Dr. Bamji? Remove the headphone and talk. Remove your headphone and talk.
Disconnect it with the computer, not connected. Type it.
Type the question. Okay, we are still not able to get your question. I will answer you. I will talk to you at a later time. Thank you. If there are no more questions, then may I now request, I will stop my sharing. And may I now request Dr. Reddy to begin his presentation. Screen share, how do I shut?
Shut the power.
Shut kar. Dr. Reddy?
Yes, ma'am. Just a minute. Let me open my presentation and
Fine.
start the screen sharing.
You know, you have all the time in the world. Please address the most important health issues. There are no time constraints at all.
I have to tell you something, ma'am.
Yes.
I think it's nearly 15 years that I spoke to a group of people. I mean, in meetings I was speaking. Let me see how much I retain from my past. And this is also a new medium without looking into the eyes of the audience. Speaking to a group, I mean, virtual group is the first time that I'm doing. So let me first of all get hold of this screen sharing and other things which are new things for me.
Okay.
Can you? So how do we do that? Can you see them now?
Yeah.
Okay.
Put it on.
Yeah, that's what I'm trying to do. That.
Yeah. In the right place. Yes.
All right. Thank you, ma'am. I think much of the background has been provided by you, and I can skip some of the slides. And instead of doing that, there are 1 or 2 points in addition I wanted to make. The thing is, you have been very optimistic. I wish I could be as optimistic as you are. The reason why I say this is, I was looking at the history of pandemics. You can see from this slide that I have put from 1881 onwards, how many pandemics we had. And that it goes into the second slide. I'm going to show that. And in 1881, the pandemic we had was 5th cholera pandemic. That means preceding that, there were 4 more cholera pandemics and there were plague pandemics and so on. That's not important. What is important for me is, despite so many pandemics, every time we start looking at what are we supposed to do for the next pandemic, invariably it works out to be a kind of knee-jerk reaction every time we come up with a crisis. That is one point I wanted to make from this slide. And there is another thing I wanted to. You take a look at the bottom 3 rows. 2003, we had SARS pandemic. 2009, swine flu. Of course, we didn't have in this country MERS, but 22 countries were affected. And then you go to the next slide. Here, I mean, leave HIV. Ebola in 2013, Zika in 2015. In a matter of 2 decades in this century, including the current pandemic, we had 6 pandemics. The 6 pandemics is quite a lot. I mean, practically every 3 years you have a pandemic if you average it. Why is it happening? It's widely known that we have been meddling with our environment and we have been facilitating, say, the interaction between animals and human beings and facilitating the, what do you call, species barriers be jumped over and come to human species. That's why we are facing these new things. Despite this, despite seeing all this, our preparedness seems to be a big issue. And I hope, as you said in your presentation, we are actually becoming cognizant of all these issues and we are going to be well prepared. To me, it appears there may be, if we control, by the time we control the present pandemic, there is one around the corner which we may have to face. And the problems that are going to discuss probably could be minimized, not averted, but minimized if we were only prepared. And one of the things that is important in preparation is the investment. Somehow, the investment, sorry, this is, okay, thank you, I shall do that. No, I didn't understand. You want to control this?
Actually,
Yeah. Can I do it myself?
Dr. Reddy, if you can expand it to full screen.
press F5 button. Ask him short.
So, that's it.
Yes.
It's done. Thank you.
Okay.
See, some are viewing it in their mobile. That is why this request.
Okay. I'm sorry about that.
No problem.
All right. Now I'm not going to go through this. That is one point that I wanted to make, because our preparedness is always somehow, it's not meeting the requirements. The second thing, in these things, you have explained where it started and how it moved and what are the things. I don't want to go into that. There is only one point I want to make as far as the evolution of the pandemic is concerned. At the peak, we had as many as 10 lakh cases. The highest number was 10,18,000 in a given day. And from September 1st to October 15th, on any given day, there were 8 lakh cases. And this we need to really compare with the capacity we have. In India, there are 93 lakh beds according to 2015 statistics. Out of these 93 lakhs, there are many in private sector as well. Of course, proportion is more in government sector. But if you actually take away so many beds for this thing, naturally there is so much of staff redeployment and non-availability of ICU beds, etc., which is one of the reasons for the problems that we see with respect to healthcare at individual level. Now, I'm not going to go into the other details which I have already provided. I want to share with you some data from National Health Mission. The National Health Mission data analyzed for the months of, say, February, March, April, it provides a comparison between 2019 and 2020 for the month of February, 2019 and 2020 for the month of March. This is first column and the third column. And in between, there is the difference between February 2020 to March 2020. It is shown as utilization of the services, OPD services for chronic diseases. Without going condition by condition, you can clearly see it is February when compared with 2019 February, there was an increase. But March, when you compare with the March of the previous year, there was reduction in the utilization of the services to the tune of 70% in the case of cancers, and in other diseases, 35 to 50% range. And diabetes, it was 16.5%. Even when you compare with the previous month's utilization, compared to February, in March, there was, severe, I mean, a very sharp reduction in the utilization of OPD services. Similarly, when we talk about the inpatient services, same trend is seen. Here, inpatient service utilization is shown for communicable diseases like malaria, dengue, typhoid, and so on. Again, you can see March when compared to the previous year, 2019 March, about 1/3 of the quantum has reduced in 2020. And even compared to the previous month, there has been significant reduction. Look at the emergencies. Emergencies, if you do not attend, there is high risk of mortality. Even in that case, you have something like 30% reduction in the utilization. These are all actually attributable to what you have already described, what Dr. Ramachandran has already described. That is basically inability for people to move because of the movement restrictions, non-availability of transport. The other thing is the perception of, the fear that they may acquire COVID infection if they go to hospitals. This has actually had enormous impact on this thing. What happens if you don't seek care in time? You are going to delay. And if you delay, the severity of the condition increases and mortality risk increases. Anyway, having said that, I would like to focus on the national health programs. If you talk about health of the country, one of the important things is to look at the national health programs. If you take a look at National Tuberculosis Elimination Program, this is one program where a lot of work is going on because we have stiff timelines. The global elimination targets are for 2030, but in India, we pronounce that we are going to eliminate TB by 2025. But according to Health Ministry, they say that there has been underdetection of cases during the period of in March and April, March to May. The 70-day lockdown left millions of TB sufferers with reduced access to crucial drugs, doctors, and follow-up of treatments. Registration of new cases between January and June dropped by 25% compared with the corresponding period in 2019. This underdetection, as per the model-based estimations, could result in an additional estimated 87,700 TB deaths in 2020. The irregular access to drugs, test for both TB and COVID. I mean, I happened to contact the director, DDG, Deputy Director General of in charge for tuberculosis program, NTAP, Dr. Sachdeva. He is optimistic, though he accepts that there has been severe setback for the program in the months of March and April and May. He sees they can actually recover, say, in the next this thing. Just a minute. Sorry, I'm sorry. So he says there are few things that are helping that. Now they started testing people. I mean, all those who are reporting with suspected COVID are being tested for TB also. That way the case detection will improve, he says. And use of masks have positive impact on the transmission of TB also. Therefore, he says, probably they will be able to meet the 2025 targets. They will be able to compensate for that. This is again that National Health Mission data. There has been lab tests have reduced, and see the number of even pregnant women who are coming for TB tests, and HIV patients who are coming for TB tests. All that has shown a reduction. But finally, we go by the word what Dr. Sachdeva has said. they are not that pessimistic about this. They think with the improved measures, they should be able to make up for the difficulties that they faced in the beginning. Now, the second program, important program, is National AIDS Control Program. I do not have much data from within the country, but the WHO says there are severe ARV stockouts in several countries. And I don't have actually stockout situation of India. In 73 countries, the WHO's report says ARVs are curtailed because they are not able to transport during this pandemic period. And much of these ARVs for Africa, etc., come from India. From India, the transportation is curtailed. That's what they say is one of the problems. And because of the rapid spread, there are some other problems. The people are not able to collect their monthly drugs, and they are not able to get their tests done. And as a result, if they fail to take the ARVs, if there is a default, your CD4 levels again go down, viral loads increase, and they lead to new infections and increased severity of the disease. And keeping this in mind, again, model-based estimations show at global level, 123,000 to 293,000 new infections may come up because of these defaults. And additional deaths they project will be 69,000 to 148,000 between 2020 and 2022. For India, we have only limited data available. The condom distribution, which is one of the essential things for prevention of transmission, there has been disruption, and the number of courses that have not reached the target population is equal to 25 million couple courses. In Goa, one of the reports by one of the NGOs, it says they are not able to actually reach the drug packets for them, monthly drug supplies to people on ART. Even when they use volunteers, majority of these these HIV patients, AIDS patients, they don't disclose their status to their families. Because of that, the volunteers are not able to go and deliver the things. All these things, as said, again, they are going to have an impact on the transmission, causing more new infections, and on the severity, causing more deaths. On MNCH front, fewer women are accessing antenatal care services. Women are arriving at facilities later and with serious complications such as eclampsia. One of a group of countries, including Bangladesh, Nepal, etc., in that meeting, what came out was people are not coming at all to the facilities. And they said some people pointed out, home deliveries are taking place. But are they under the supervision of trained birth attendants? The data that I'm going to show next will tell you that not all are covered by trained birth attendants. There has been reduction in that also. Even for those where trained birth attendants are attending and conducting the deliveries, is there any preparation? Is there any support for these people? Any training for these trained birth attendants to conduct the deliveries in these COVID times? Have they been trained? There is no indication of any such effort. And as I said, the number of home deliveries reduced by 25% under the supervision of the skilled birth attendant. And so did the things like, say, syphilis testing and eclampsia cases, etc. In India also, there has been significant reduction. Now, the impact on immunization is something that is immunization for any of us. I am a public health worker. For me, if there is any effective tool for prevention, immunization is the topmost. And this disruption of immunization means a lot of increase in the burden that we are going to have. Due to increased burden on health infrastructure and resources and transport delays, this has been disrupted. And globally, 80 million infants missed vaccination at the risk of disease, according to WHO and UNICEF. Now, during COVID, mass immunization campaigns are halted. And there is also decreased demand for vaccination because of physical distancing requirements and community reluctance. Indian Academy of Pediatrics projects every week 5.5 lakh children go miss their vaccination, start of their vaccination or the subsequent booster doses. That number, and by the end of April, that is during March and April, what accumulated, that was 32.4 lakh children, according to that report, were partially were not vaccinated or were partially vaccinated. And this is again 69% was the dip in the vaccination for measles, mumps, and rubella, and others were, there was a dip by the by 15% or 16%. Mental health is another problem that has been widely written about and widely talked about also. One of the studies by Jindal School of Law, they have done a study, a cohort of 300 non-coronavirus deaths. And among these 300 non-coronavirus deaths, when they started looking for the cause of death, suicide was the cause in majority. The leading cause was suicide, which reflects the mental health issue. And a survey by Health Parliament among 461 students, it shows disturbed sleep patterns, loss of interest in performing tasks, reduced motivation to study, etc. I mean, in different degrees, 29%, 26%, 20.7%, and so on. But what is important is, so I wanted to see what is the prevalence of this mental illnesses or these conditions which are listed here. The only way I could do it was I started looking for what percentage of people did not have any of these conditions, and that was 1%. That means 99% of the people in that survey reported one or the other of the listed disturbances. It sounds a little too high. I thought even if there is a bias by 50%, half of 99% is close to 50%. And what is known about mental health illnesses and normal times is 10% of the population present with this kind of disturbances. Now 10% to 50%, I don't think I have to use any words to say that there is enormous this thing during this COVID pandemic and lockdowns, that many people are undergoing these mental problems, mental stresses, and so on. Another national program, National Blindness Control Program. Usually, if you take 2018 and 19 statistics, about 5.5 lakh cataract surgeries are carried out every month. But during lockdown period, till the end of May, all the surgeries have been pending. And in 51 days, not even till the end of May, by May 30th, as of May 30th, according to this paper, 947,000, that is 947,000 surgeries were pending because they were not attending to anything at all. There is also another issue with this thing. COVID-19 presents as viral conjunctivitis also. Often that is missed and it is mistaken for something else. There is always a risk of getting exposed for ophthalmologists. Of course, naturally, if one follows the guidelines and takes all the precautions, this can be avoided. But the fear is induced in the minds of these ophthalmologists. They want to be extra careful when dealing with this thing. They think cataract is not a problem that has to be attended to immediately, and they tend to postpone. As a result, the national program is actually suffering. But I have only described about the adverse impacts of COVID-19 and lockdown related to, associated with that. As Dr. Sachdeva, Kuldeep Singh Sachdeva, that is DDG, pointed out, there are several beneficial impacts also. We should not actually close our eyes to that, he said. Disguised within this gloom, there were some positive impacts. The reduction in vehicular traffic resulted in reduction in road traffic accidents and also in air pollution and related morbidity. The positive impact of wearing masks on respiratory illnesses like TB. And there was also one report which described that there has been reduction in gastrointestinal infections such as hepatitis, gastroenteritis, and typhoid, hepatitis A and E, which are waterborne. But I really do not know. Basically, this could have been because of the fact that people were not reporting to the health facility. Sorry. So, as I said, when I talked about this thing, there is, when I was a student, people used to tell us, study your diabetes well, you will master medicine. When I was working and I used to work in HIV, people used to say, hey, master HIV and AIDS, you have mastered medicine. Now, I think a third condition is getting added to that list. COVID-19 involves many systems. This multi-system involvement, I need not go on reading the entire thing, from cardiovascular, endocrine, renal, oncologic, neurologic, and so on. So this is one thing. When it has actually COVID-19 there is an interaction, as a matter of fact. Instead of calling it as an impact, there is an interaction between different diseases or comorbidities and COVID-19, enhancing the risk of mortality and risk of morbidity. So let us quickly go through some of these conditions which are increasing the risk for the health of the people and increasing mortality as well. Foremost among them is cardiovascular diseases. There is a direct impact of COVID-19 on the patients of cardiovascular diseases. The risk is higher. See, there are three conditions which are considered to 3 or 4 morbidities, which are comorbidities, which are increasing the risk of mortality. That's what we read. Age, after age, CVDs, diabetes, chronic kidney disease, and pulmonary diseases. With all these comorbidities, people are tending to die more compared to those who do not have it. But among them, when you make a comparison, case fatality is higher with CVDs compared to cancers and pulmonary disease by 10.5%. Why? Because COVID-19 itself, the SARS-CoV-2 itself is causing certain cardiac problems because of inflammation it causes, because of microthrombi it causes. Both of them are leading to certain, cardiac problems. One is, there is an increase in cardiac arrhythmias by 16.7%. And it also causes fulminant myocarditis, leading to acute heart failure, cardiogenic shock, and asymptomatic myocardial inflammation. And the indicators, troponin levels are leading to increased mortality risk. ACE2 inhibitors were also suspected in the past, and they used to write, but I have seen subsequent articles saying that it was only suspected, but there is no role of ACE2 inhibitors. The services to these CVDs in the country, I mean, though they have all these problems, are restricted. Why? There is restricted movement and poor transport resulting in delays. And also, there are efforts to minimize the exposure of healthcare workers to this thing. And there are certain protocols in place. These protocols are, when a patient comes, he is put in a holding area, tested. When the test result comes, then only he is taken up for intervention. right? And also you have infection prevention control measures are one of the standard or part of the protocols. They also take its own time in COVID area compared to normal areas. In this, there are two things that are happening. In cardiology parlance, there are two indicators which are important. One they call golden hour. That means from the onset of the symptoms to intervention. It should be, in Western countries, they use usually 3 hours as the period. But in India, we say it should be done within 12 hours. This golden hour is 12 hours. And that has prolonged, increasing the risk of mortality. If it goes beyond that, mortality risk increases. And second thing is the sterilization protocols, PPE requirements, that IPC requirements that I spoke about, they also increase even after the patient reaches the doorstep of the hospital. From there to the time he is put on the catheter in cath lab and on the table, and then the PCI, percutaneous intervention is started, or even thrombolytic intervention is started. Between that, the time is called door to balloon time is done, because balloon is what they use in PCI. That time is also increased. It should be half an hour to 1 hour, but it's going to several hours. This again is increasing the mortality risk. And also, there is third thing which is actually causing a worry. Elective procedures like mitral valvotomy are rescheduled or cancelled. Usually, in some cases, serious cases, the patients tend to deteriorate very quickly. When the seriousness increases, they start bringing under the difficult circumstances, again leading to mortality, high mortality. There is one more issue. In the presence of COVID, the people present as ST segment elevated myocardial infarction. That's not because there is any block in the arteries, but the microthrombi actually reduce the flow of the blood. And because of inflammation, the heart's requirement, oxygen requirement increases. Because of the mismatch between the supply and demand, they present as, myocardial infarction. There has been a lot of debate about this. What kind of thing should we use? Thrombolytics, or should we use different? China is using a different thing compared to USA. So that is percutaneous intervention, which one needs to be done. Like this, the new challenges are also being thrown at the health services when it comes to these cardiac diseases. The next one is diabetes and endocrine disorders. See, whatever we said in cardiac diseases holds good here. And all the delays and no lack of follow-up visits, it is causing one problem. And because of the immunocompromised status, both susceptibility as well as severity increases. The third thing is behavioral thing. During COVID period, during this lockdown period, there is no poor exercise. Gyms are closed. Even I myself am an example. I am not going on walk. I used to be I used to walk 5 kilometers in the morning and 5 kilometers in the evening. Now I am not walking even 500 meters. So lot of the exercise, poor or no exercise or sedentary habits are increasing. And food, because people are not ready to go to the market and pick up the food, unhealthy food intake, food practices are increasing. You get some packed food and keep it ready when there is no vegetable did not come, you start eating that kind of things. And the third thing is, as I said, follow-up of patients is affected in diabetes. That's very important requirement that's affected. In respiratory and pulmonary diseases, usually once patient becomes negative, it takes some time, but there is resolution of the lesions, lung lesions, in a significant number, a good proportion of cases. But there is a large proportion of the patients of COVID who actually have residual damage. The residual damage is of two kinds. One, among those who already have chronic pulmonary disease, and the second, the newly infected people. They don't have any previous chronic pulmonary disease, but the pathology caused by the COVID, it is continuing, and it actually ends up as interstitial lung disease. Whereas in those people who had previous disease, previous chronic pulmonary disease, there is post-COVID-19 fibrosis in some and permanent pulmonary degradation in most of the people who have chronic pulmonary disease. So, and another thing related to respiratory and pulmonary diseases, it also is applicable for anesthetists, etc. The procedures performed in these people for pulmonary diseases, they increase the risk of or exposure to the virus of the healthcare providers, right? And third thing is the mechanical ventilators. Now they are diverted, most of them are diverted for taking care of COVID patients. And when a non-COVID respiratory disease person reaches, there is a competition for mechanical ventilators. And there has been, there have been problems in getting these ICU beds and mechanical ventilators, etc. I shall show it in the next slide. And susceptibility and spread increases because of use of, smoking, e-cigarettes and hookahs, etc. And okay, I think I missed that slide. There has been actually, people needed clout to get those beds, ICU beds, at one stage because of the shortage. Those non-COVID patients had a problem in getting the beds. That slide somehow I missed, or maybe it got dislodged. And the next condition is most important. I said 4 important comorbidities. Among them, renal or chronic kidney disease is one. In India, the problem of CKD is quite large. It is estimated that 800 per million population have chronic kidney disease. And out of them, 150 per million have end-stage renal disease. It's a huge problem. And many of the people who are CKD patients, they are on renal, hemodialysis. And those, if they do not get hemodialysis at the prescribed intervals, they have a problem. The uric acid levels increase, and then the complications start occurring and mortality risk increases. And this is happening during this period, particularly during the lockdown period. There were delays and also decreased availability because staff reallocation or redeployment. And postponement of the dialysis, deterioration, and higher mortality. Yes, patients, these for patients on dialysis. Comparison of, there was a study where they compared the mortality in a cohort of 3,183 insured dialysis patients in 2019 and 2020. And they were compared with a historical cohort of 2018 and 19. The excess mortality compared to 2018-19 cohort was, in May and June, there was 64% increase in the mortality. But after the relaxation of the lockdown started, it started decreasing, 25% in June and 22% in July. You can see this from this graph. See, this is the maximum was in May, then it started decreasing. So the lockdown had this impact, and it in fact resulted in increased mortality. And various reasons offered for this mortality was 62% said different kinds of disruptions, travel barriers, switch to new hospital, difficulty in getting medicines, hospital closure, increased hospital charges. They all have been, one or the other reason has been there. But the thing is, the persons lost their lives. Now, the COVID has its impact on sexual and reproductive health also. There have been unwanted pregnancies and unsafe abortions. And at least in one writing, this is not in a scientific journal, a Quint, some web-based news channel, they wrote, there are, many people who need abortion, they are opting for using the contraceptives, and they are available easily. They are available easily in the neighborhood pharmacy, and they are taking it. And when the complications arise, then they start running, and with all the problems associated with it. And also, elective gynecological procedures like tube ligation are postponed. And there are also problems with the policies related to newborns. There is always this thing, whether should the newborn be kept with the mother or otherwise. Now they say separate the baby from the mother, but for feeding purposes, I'm sorry, I have phone calls. For feeding purposes, you use all the COVID appropriate behavior, masks, etc., and mother will feed the child. That is the current advisory. So similarly, neurological diseases are also, there is an increase, particularly because of autoimmune neurological diseases like multiple sclerosis, etc. They have long immunosuppressive therapy. Because of that, their vulnerability increases, vulnerability to COVID, and the disease becomes severe. And COVID-19 is associated with strokes and transient ischemia, and possibly they are of thrombotic origin, that microthrombi that I said are caused in COVID-19. So the other problem is these cancers and hemoglobinopathies. These pandemic control policies are playing a role here too. There are disruptions and delays in delivery of care, because of which transfusions for hemoglobinopathies are affected, therapeutic interventions in cancers are affected, secondary screening is affected, all again leading to severity of the disease. Blood banks are also impacted owing to restricted movement, and blood donation actually is decreasing. Patients with hemoglobinopathies are those on chemotherapy or on bone marrow transplant have higher mortality, and need for mechanical ventilation is increasing. So emergency procedures have the same problem. There is a long waiting time. They are left in holding area waiting for a test result. Problems associated with infection prevention control measures. Problems associated with anesthesia, as most anesthetists and critical care specialists are on COVID duty. Only limited number of surgeries could be done. For a period in the beginning, several of these services were closed, in fact, in many hospitals. It's only later there was an advisory. They started providing services on a limited scale. And as I already said, blood and blood product availability has decreased because people are not donating. And staff reallocation and staff quarantining is another thing. See, what is happening in the hospitals? Let us suppose there are 30 people in a particular department. 10 would be posted in COVID ward, and 10 would be, after they complete this thing, they will be on quarantine, and the second 10 will come. And only 1/3 of the people are available in the hospital for regular care. As a result, so the inadequacies are arising. People are not able to meet all the meet the demand. So that is what is the staff reallocation problem. And many had to shift to private hospitals. Some hospitals are not refusing, are in fact making them waiting for the test results, because not all hospitals are testing for COVID. And the charges are exorbitant in these private hospitals. So we can summarize the factors which are causing these disruptions and delays. They can be classified into health system related, health services related, and lockout related things. health systems, inadequate in infrastructure, shortage of beds. See, beds, what we have, I already told you about, we have about 19 lakh beds, and there are 10 lakh cases on a given day of COVID. So naturally, many of the people who are patients of other diseases, they have to suffer this shortage more. It becomes more acute. Manpower, of course, you all know these things. The the patient ratio, it is 0.7 to 1, nurses are 1.7, and pharmacists are 0.2, where there should be 1. All this is the result of inadequate investment in health. And health services related problems are delay or cancellation of elective procedures, reduction in donations, leading to non-availability of blood and blood products, delays in diagnosis and treatment of NCDs, failures in surveillance, monitoring, and treatment delivery. That is like in TB and HIV, as I explained. Postponement of hemodialysis again is leading to increased mortality. And lockout related things are the mobility restrictions and loss of jobs and subsistence, etc., are other problems. And the behaviors are also affected, health behaviors. As I said, reduced physical activity because of fear of exposure, limited access to gyms, etc. Unhealthy food choices, domestic violence and child abuse, and IPC and infection prevention control and biomedical waste management are affected. And one of the important things is burnout of the health workers. They are so overworked nowadays. I mean, clearly there seems to be enormous burnout among the health workers, doctors, nurses, and so on. This in turn is leading to mental health among the healthcare workers. And as such in the population also, there is adverse impact on the mental health of the people. To conclude, COVID-19 pandemic and policies to control it caused setbacks to the national programs such as TB and HIV. They hampered progress towards achieving SDG 3. That's as I was mentioning about HIV and TB and HIV. Resulted in higher non-COVID mortality with respect to 2019. Risk of severe complications and death from COVID-19 among people living with NCDs has been enhanced. Weakness in health systems are exposed, and need for investment is highlighted. And thank you, that's all I have to say. And if there are any questions, I am ready to answer. Thank you. Sorry.
You have really finished well ahead of time, Dr. Reddy. And I'm sure there are going to be questions. We will wait for the next few minutes.
Yeah, I should wait.
You can, the participants, you can unmute and ask questions if you are having problem in typing in the chat. I have unmuted. No, I'm unmuted. I'm unmuted. No
How
problem.
do I come back?
I'm unmuted. No problem.
Sorry, I am.
You have been so clear. In case at the moment there are no questions,
Okay.
but I'm sure what is going to happen is you will receive questions sometime later. We will be able to send them to you using the using your email, and may request you to kindly respond to them.
Okay. Okay.
There is one question. Okay, chat. One sec. Okay,
unable to
Dr.
repeat.
Gustafson.
Yes.
When might we expect to see the improvement in diminishing the impact of COVID on other services? Now put on your visionary vision.
It's a my screen sharing is past. I think stop share. Okay. Now I'm
You can stop sharing.
I did not find that button.
Okay.
The question is when we can improve, see improvement in this situation, is it?
Yes. When might we expect to see the improvement in diminishing the impact of COVID on other health services?
I hope it's in relation to India's situation.
Yeah.
Because, Okay, right now there has been considerable improvement in the situation. What I described is mostly during first 70 days of lockdown, all the figures were immediately following lockdown, the studies were undertaken. Now, there has been relaxation of many restrictions that were there gradually over 4 phases, they brought down many of them. Even then, because the pressure on the COVID wards has come down, and the number of people diverted towards COVID wards also has reduced, and situation has improved. But having said that, people are always on the, say, what you call alert. We really do not know the kind of decline that we are observing. We are happy about that, but we do not know we are not going, I mean, we cannot really say that we are not going to have the second wave. If one looks at the graphs of, say, USA or European countries, there for 1 or 2 months, they were at a very low level, and suddenly the second wave came up, and in USA, the third wave also came up. So until and unless we complete this immunization, which is going rapidly, and we have to be on the alert, and we expect some pressure to be there. There was also one question to Dr. Prema Ramachandran by you, that was actually why 60%? Why 60% is because those 60% and 50% things are in urban areas. In some of the localities where there has been very high magnitude of COVID, like Bombay, Delhi, and so on. But we had some surveys which involved the rural areas also. There have been 3 national surveys, and they indicate in rural areas, the prevalence is much lower, and also in some of the smaller towns. In fact, at one stage in the country, 5 cities of the country accounted for 50% of the problem. Therefore, the situation also will be diverse in the country. In some places, they will come back to normal very quickly, and it's happening also. In South, some of the states, the general services are improving quite rapidly. And in some places, like in Delhi, etc., they are taking time. That's what the situation is. I think I can't give you the third survey figure because it's not officially announced. I think if we cover about, say, half of if the moment we expand our immunization coverage to rural areas, I think we should be in a better position, because there is still a lot of vulnerable population there. In the cities, probably we shall come to the herd immunity level. Probably it will not take very long. With already pre-existing immunity, with this current immunization activities, we should be able to come. Does it answer your question? Yeah, there are so many questions here.
Yeah, okay. The second question is from Dr. Kamla. In spite of personal protection, what about the mortality in healthcare workers?
Well, there have been reports that there was increased mortality among healthcare workers. All those reports come from the earlier days. Nowadays, what we are seeing the trends is that there is reduction in that kind of healthcare worker mortality. Now, in the initial stages, there has been more exposure, it appears.
Any more questions? Dr. Gustafsson, any comments if you have now on the other two presentations?
Yes, no, thank you very much. I think I found both of them really extremely interesting and surprising, I think, in a number of ways, I think. But in particular on really how well the response has worked out, I think, with this, of course, massive number of migrants and the ability to scale up social protection programs. I think it's just phenomenal. But it does also, I think, in Dr. Reddy's presentation, illustrate how connected everything is, right? And it's the impact on diseases that we would think would not be related to COVID is, of course, very much related because of the lack of attention that they have been receiving, the lack of vaccinations and other things. I think I found both of them just fascinating. I'm hoping that we might be able to let's say, see the PowerPoints after the event also. I think they're just really full of very interesting information that I hope we could have access to.
We would get the permission both for the recording and for the PowerPoint presentation. We hope to put the recording in the YouTube and PowerPoint in NFI website. Dr. Deep Srivastava, any comments?
This went a very nice topic, this lecture. I did not listen. What you wanted from my side?
Any comments or suggestions?
None, no, madam. It's good, madam.
Oh, okay. If there are no more comments, questions, or suggestions, then can I thank the speakers? Okay. I thank the speakers for excellent presentation. And I would like to remind the participants that we are going to send you all the evaluation form. From the list of people whom I see have attended, I don't see anybody requiring any certification. So you can skip that without any difficulty. Okay. I would like to conclude by saying that COVID pandemic is a once in a century catastrophic challenge to all countries, all segments of population, and all sectors of activity. But will you please also recognize that challenges and opportunities are two sides of the same coin. Successfully coping with challenges adds to our strength and to our confidence in dealing with such challenges. Today is Budget Day in India, and by now, the Union Minister of Finance would have presented the budget, which would have outlined priority segments and sectors which will require stimulus and the quantum of stimulus that will be provided so that GDP growth bounces back as was projected in the economic survey. We hope that these targets would be achieved within the time frame. We also hope that the stimuli will hopefully result in equitable growth for all sectors and improvement in employment and wages, which are critical at the time point. From us, who are mainly concerned with food security, nutrition, and healthcare, there are two pleas. Access to food and healthcare are essential for life. Ensure that agriculture does get the attention and input it deserves as a priority primary sector responsible for food security and nutrition. Let farmers have the economic incentives and other incentives to be productive and diversify so that appropriate food is grown in adequate quantities and provided to the population. This is an essential prerequisite for us to have food security and optimal nutrition. From the health sector, the plea is, please accept that universal health care is essential. This is to ensure that appropriate preventive, promotive care is provided. Health education, healthy lifestyles are made available across segments of population, as also healthcare for communicable and non-communicable diseases and other problems. May we hope that both these pleas might be listened to with greater care and perhaps realized sooner because of the COVID pandemic, which has enabled us all to identify priority core sectors for living. Can I thank all the speakers and the participants once again? And can I also close the session? Thank you very much. Yes,
Thank
Dr.
you.
Gustafson.
Thank you very much. No, I think it was just a wonderful session, and I'm glad that that I could participate in it, and really I've learned a lot from this, and I look forward to continuing to be in touch with the foundation. Thank you.
We will be in touch with you, as had always been the case. I would begin by asking you, dear Dr. Gustafson, will you please send us a write-up on this so that it could go in the April issue of NFI Bulletin. So we will be in touch. And thanks to all the participants for having spent.
Sorry, madam, I was out for 2 minutes because someone was waiting for me. Did you say something to me?
No. I said thank you very much for your excellent presentation, which covered
Thank you.
really the wide gamut. And Dr. Reddy, you have done what I requested you to do. COVID is easy, but its impact on other sectors is something that we did not have enough data on the health sector. And you did a marvelous job on that. And perhaps we will give you a little respite, but after that, sometime later, I will also request you to write about this for the NFI Bulletin, because most people are unaware of these. Their focus is totally on COVID and COVID and COVID. You know, lives lost because of inadequate attention to others may sometimes exceed that of those lost to COVID. And this is a focus that we need to bring back. So I will come back to you with that. May I thank all the participants for their participation on an early Monday morning webinar. Thank you and goodbye.
Thank you. Okay.
Thank you. Thank you, madam. Thanks.
Thank you, Dr. Deep.
Thanks a lot.